The ankle joint complex is comprised of the lower leg and the foot and forms the kinetic linkage, allowing the lower limb to interact with the ground. The osseous anatomy of the ankle consists of the tibia, talus, and fibula. The bones of the ankle joint are connected through the synovial hinge joint formed by the tibia and main weight-bearing surface of the talus. The ankle joint is frequently referred to as a complex, as there are multi-axial motions occurring simultaneously. We will be focusing on the distal aspect of the tibia seen here on the anterior view, as this is where we gain access to the anterior joint. It is composed of the medial malleolus and has the anterior colliculus and posterior colliculus. The area between the two is called the intercollicular groove. The distal posterior aspect of the tibia is called the posterior malleolus. These landmarks help when orienting yourself within the joint. Other landmarks include Chaput's tubercle and the anteromedial tibial notch of Hardy. The tibial plafond is the weight-bearing aspect of the distal tibia, getting its name from the French word for ceiling and is viewed here superiorly. The fibula has the distal tip referred to as the lateral malleolus. The tibial plafond is covered with cartilage and articulates with the talar dome. The talar dome is a common area where lesions are seen on arthroscopy. The talus itself is wider anteriorly than posteriorly and contributes to the formation of the ankle joint. The talar dome is convex from anterior to posterior, and in most cases there is a longitudinal groove running from anterior to posterior, toward the medial aspect of the dorsal surface. The medial surface of the talus consists of an upper articular surface and lower non-articular portion. The articular surface is comma-shaped, similar to the lateral surface of the medial malleolus, which covers it. The junction or shoulder area between the dorsal and medial articular surfaces of the talus is described as rounded and continuous medially with the medial malleolar facet of the talus. It is also continuous laterally with the lateral malleolar facet of the talus, which is the concave triangular area found on the lateral aspect of the body of the talus, which articulates with the articular facet of the lateral malleolus of the fibula, contributing to the formation of the ankle joint. This area is also commonly known as the lateral gutter. The talus is divided into three regions: the head, the neck, and the body. The talus has a unique articular surface anatomy, as it covers about 60% of its surface and because of this, limits access for incoming vascular supply. It is worth noting that an accessory bone can be found in some patients, called an os trigonum, which is located next to the lateral tubercle. This can sometimes cause posterior ankle impingement. Not to be confused with a trigonal process or steta process, that is an elongated posterior lateral talar process. Superficially, we can appreciate the surface anatomy of the anterior ankle, medial ankle, posterior ankle, and lateral ankle, as key landmarks are marked out on the patient prior to creating any portals. With dorsiflexion and plantar flexion, different areas of the talar dome can be accessed. During dorsiflexion, seeing less of the cartilage on the talar dome. This is important when gaining access to lesions anteriorly versus posteriorly. Branches of the superficial peroneal nerve, or SPN, are usually visible, with inversion of the foot and plantar flexion of the fourth toe. But keep in mind, the nerve moves laterally in the neutral position. This is important to note, as the SPN can move as the portal is being created, depending on where the ankle is positioned. When the skin is removed, a variety of superficial structures are seen that can be appreciated with this cross-section just above the ankle joint. Here we see, from lateral to medial, the extensor digitorum longus, then the extensor hallucis longus, and tibialis anterior. It is paramount that the anteromedial portal is made medial to the tibialis anterior tendon to avoid the anterior neurovascular bundle. Looking posteriorly, we have the Achilles tendon, then the flexor hallucis longus, flexor digitorum longus, and tibialis posterior tendons, which start posteriorly but then pass behind the medial malleolus before staying medial. When discussing posterior portals for access to the ankle joint, the Achilles tendon is the major landmark to stay close to for both the posterior medial and posterior lateral portals to avoid neurovascular injury. Posteriorly, with the Achilles removed, the perineals, the muscle belly of FHL, and the neurovascular bundle are seen here. Appreciating the anatomy here will help to avoid any iatrogenic damage to the neurovascular bundle. On the medial side, deeper to the tendons, is the deltoid ligament complex. Laterally, you can see the retinaculum, peroneus longus, peroneus brevis, and peroneus tertius. Deep to this, visualization of a number of ligaments becomes more evident, the ATFL being the main ligament that is repaired arthroscopically. The ankle joint is stabilized by the lateral ligaments, the deltoid ligament on the medial side, and the ligaments of the tibiofibular syndesmosis that join the tibia and fibula. The lateral collateral ligament complex consists of the anterior talofibular ligament, or ATFL, the calcaneofibular ligament, or CFL, and the posterior talofibular ligament, or PTFL. The medial collateral ligaments, also known as the deltoid ligament, are a multifascicular group of ligaments and can be divided into superficial and deep fibers. The anterior talofibular ligament is the most frequently injured ligament of the ankle and plays an important role in limiting anterior displacement of the talus and plantar flexion of the ankle. It runs anteromedially to the insertion of the talar body, immediately anterior to the joint surface occupied by the lateral malleolus. The ligament is virtually horizontal to the ankle in the neutral position, but inclines upward in dorsiflexion and downward in plantar flexion. This is important when locating the insertion site on the fibula for both assessing the ligament and when repairing it. The ATFL is traditionally described as a single bundle structure, but there is frequently a common fibular attachment with fibers shared between both the ATFL and CFL, described as the lateral fibulotalo-calcaneal ligament, which is the ATFL's inferior fascicle, plus the CFL, plus the arciform fibers. The ATFL can be seen, specifically the superior fascicle seen here inside the joint capsule. Once it ruptures, it becomes intrasynovial, which prevents its healing. The ankle joint capsule inserts beyond the articular cartilage on both the tibia and talus and has regions that are confluent with the ligamentous complexes of the ankle. The average attachment sites of the capsule reported as 6 mm proximal to the cartilage rim on the tibia and 3 mm from the distal cartilage border on the talus. Capsular attachment at the level of the ankle joint, shown in this sagittal illustration, was studied further by Johannes and Van Dyke, showing the soft tissue component attached to the joint capsule anteriorly, and they highlighted the non-weight-bearing cartilage rim on the tibia that extends 3 mm proximal to the joint line. The capsule is distended with sterile fluid at the beginning of the procedure to allow for easier access. On the medial side, the deltoid ligament complex helps support medial ankle stability. As mentioned previously, it has both superficial and deep fibers and has a close relationship with syndesmotic and ankle stability. An understanding of the anatomy is important due to the proximity of adjacent structures and establishing a safe zone for arthroscopic deltoid ankle stabilization procedures. The syndesmotic ligament complex ensures the stability between the distal tibia and the fibula and resists the axial, rotational, and translational forces that attempt to separate the tibia and fibula. There are several components that make up the syndesmosis, including the anterior inferior tibiofibular ligament, or AITFL. Here we see a torn AITFL. Its inferior band, Bassett's ligament, courses across the anterior lateral tibio-talar joint. The interosseous ligament, the posterior inferior tibiofibular ligament, or PI-TFL, is occasionally referred to as the superficial PI-TFL. The inferior transverse ligament, sometimes referred to as the deep PI-TFL, can be seen arthroscopically. Other posterior ligaments include the posterior talofibular ligament. In the cadaveric image, you can appreciate some tissue confluent with the PTFL superiorly. This is a combination of the intermalleolar ligament and capsular tissue. The syndesmosis can be assessed arthroscopically for disruption. It is also worth noting the fatty synovial fringe, which is a small bundle of adipose tissue distal to the insertion site of the interosseous ligament. It retracts and descends and can cause soft tissue impingement during dorsiflexion and plantar flexion, and can be involved in posterior soft tissue impingement syndrome of the ankle. Finally, we will cover the neurovascular structures. There are 3 arteries which perfuse the ankle: the fibular artery, the anterior tibial artery, and the posterior tibial artery. A branch of the anterior tibial artery, the dorsalis pedis, runs in close proximity to the anterocentral portal. As a result, this portal is rarely used. The posterior tibial artery travels with the tibial nerve. The venous supply accompanies the arteries. The greater saphenous vein runs in close proximity to the anteromedial portal. Sensation to the lateral aspect of the foot is provided by the sural nerve, which runs posterior to the lateral malleolus. The superficial peroneal, or fibular nerve, is a branch of the common peroneal nerve. It sits slightly anterior to the fibula prior to dividing into the intermediate dorsal cutaneous nerve and medial dorsal cutaneous branch, just proximal to the ankle joint. Again, this is important when establishing the anterior lateral portal. The deep peroneal, or deep fibular nerve, is another branch of the common peroneal nerve, emphasizing again why the anterocentral portal is rarely utilized. The saphenous nerve is a branch of the femoral nerve that traverses the medial ankle slightly anterior to the anterior colliculus of the medial malleolus. Finally, the tibial nerve is a branch of the sciatic nerve that runs down the posterior leg prior to passing under the medial malleolus and sustentaculum tali of the calcaneus.